Well, with this week's Cardiology Countdown, we'll start with JAMA that has a pair of articles looking at progression to renal failure. Obviously a feared complication that two investigative groups have developed risk scores to predict who will go on to develop renal failure. The first uses a multi-marker risk score using creatinine, cystatin C, and the urinary albumin to creatinine ratio. And the second uses a list of about 8 of the standard biomarkers and other risk factors. So this may be useful to help identify who is really at risk of progressing rapidly and who may benefit from renal consultation. At the number 2 spot, a paper near and dear to my heart looking at very low LDL levels. And this is a paper from the Jupiter trial that looked in 2 ways at patients who achieve an LDL less than 50, a territory not previously explored in many trials, but comprised half of the rosuvastatin treatment group. What was seen was that event rates were lower in that group and side effects were not higher as compared with those who had higher LDL levels. They also broke out in a randomized fashion at different starting levels of LDL, and the benefit of rosuvastatin over placebo was maintained regardless of the starting LDL. Even at those starting with an LDL below 60, when adding rosuvastatin 20 milligrams, there was still a benefit on par with the overall 40% reduction in cardiovascular events. And so I think very useful safety information primarily that very low LDLs appear to be safe and also have very low event rates. And at the number 1 spot this week, we have a paper from the Annals that's a review of patient self-testing and monitoring for the INR. We've had a lot of activity of new anticoagulants that don't require monitoring, but warfarin used in the vast majority of patients does. And so there's a Cochrane review of a total of 22 trials that randomized altogether about 8,400 patients to patient self-testing with a home INR device or the standard checking in clinics. And they found a significantly lower mortality and risk of thromboembolism in those who had patient self-testing. Also, patient satisfaction scores were higher, and importantly, the risk of bleeding was not increased. And so this encourages the use of patient self-testing and or management according to an algorithm as a way to improve outcomes with warfarin. So with this week's Cardiology Countdown, I'm Chris Cannon.